Dr. Joseph Salvatore is chief of HEMONC at the VA Medical Center in Phoenix. He uses static magnetic fields to treat patients with malignancies and conducts clinical studies on these treatments. He's editor-in-chief of Electromagnetic Biology and Medicine.
The talk that we're going to be looking at this point is the use of electromagnetic fields in cancer therapy. This is a fairly new area. There have been a number of studies over the years which use electricity and magnetic fields, and then some in combined electromagnetic fields in the application to both cell culture systems and animal systems. However, in this talk, we'll briefly look at that information and then also look at the information that concerns the application of electromagnetic fields and static magnetic fields to therapy of cancer in humans. This has been a tumultuous year for both politics and medicine, so I'm going to put my disclaimer up that this talk represents my views only. Basically, we are looking at non-ionizing electromagnetic fields, and the reason I emphasize this is because when we talk about electromagnetic fields or radiation or use any of those terms, physicians and other healthcare providers will almost always think of radiation therapy, which is ionizing radiation and not non-ionizing radiation. Many years ago, there was interest in the use of electricity and magnetism, both, which were the new therapies that, as is typical in cancer medicine, when a new therapy comes along, it's believed that we found it now. Here it is. We found the answer to our problem. And in the mid and late 1800s, both magnetic fields and electricity were thought to be those therapies that would cure cancer, and we would be finished with that. The electricity on the left, you see electricity in the treatment of malignant tumors by Green. This was published in 1873. On the right-hand side is Murray's work using electricity to treat fibroid tumors. Now, those are not necessarily malignant tumors, but that work done in 1894 did advance the concept of using electricity in therapy of cancer. On the left-hand side is a very interesting paper. It was one of the first papers that I found when I was starting my research in electricity and magnetism and electromagnetic fields. And it's a story of a physician who was called to see a farmer or a farmhand who had a malignant tumor on his lip. He was then struck by lightning, and the physician was called back, and the physician noticed that after the electricity, the tumor appeared to regress. And so again, this was information that was brought forward and said, now we might have something that will help us to treat cancer other than just surgery alone, because at that point in time, not even ionizing radiation was available. So in a sense, non-ionizing radiation or electricity or electromagnetic fields were part of the consideration for therapy for cancer prior to the development of good ionizing radiation therapy, which is one of the mainstays of cancer therapy now. What's interesting about this paper is that Allison actually first published this information in what were considered to be popular magazines of the day and not in a scientific journal. And he later said that was because his letter was actually rejected, so he went to trade publications. Then when he published it in an actual journal, which you can see is the Lancet, a very prestigious journal, he actually said that he was chastised and criticized for having first published in trade journals instead of in medical journals. On the right is an expose on the use of the magnet in medicine. This was a very interesting paper, and in those days it was actually quite interesting because magnets were being used to remove pieces of metal that were magnetized and could be removed from the eye or from the back of the throat or from other parts of the human body that couldn't be accessed in other ways. Then we come a little further along, and we're beginning to see the application of electromagnetic fields, intense magnetic fields in cell culture systems, as well as in some animal systems. And these were some of the publications that early on suggested that the proper application of these fields and electricity could in fact be somewhat helpful. Again, some more of these publications which laid the groundwork for some of the work that you see being presented in the conference, in this conference. Now, when we consider doing any kind of research using magnetic fields in particular, you have to take into consideration that the Earth has a geomagnetic field. It's a stationary or static magnetic field. That means that it has a cycle of 0 hertz. And the strength ranges from somewhere between 25 to 75 microtesla, or 0.25 to 0.75 Gauss. The approximate conversion is that 1 Tesla is approximately equal to 10,000 Gauss, and so that's where you have the conversion. Now, the field lines that you see are actually field lines that are presented when you measure geomagnetic fields, and the field periodically reverses, but that doesn't happen for maybe 10 or 20,000 years, so I don't think you have to worry about that if you're taking it into consideration for doing research. Now, when you consider the geomagnetic field, what we did when we did our research was we always did daily, 2 or 3 times a day checks of background magnetic field radiation in the rooms in which we were doing the research, so that we knew what the baseline was and whether or not it was changing. These are the spectrum diagrams, which you're all familiar with, to show you that as the wavelength increases, as the wavelength decreases, the frequency increases, and that's what the diagram shows from left to right. We are mainly interested in all the way from 0 hertz up to somewhere around 300 gigahertz. Many of you know that the electric power frequencies, which are 60 hertz in the United States and 50 hertz in much of Europe, were some of the original studies that suggested that there was a relationship between exposure to electric power and the development of malignancies such as acute leukemia, especially in children, and those studies were done with electric power frequencies of 60 hertz. The work that we've done is mainly focused on static magnetic fields, which have no time variation or 0 hertz. And then the ISM is the industrial, scientific, and medical frequencies that have been set aside for the use in medicine in particular. And we see a radio frequency of 27 megahertz and microwave frequency of 434 megahertz. These are used for heating, mainly in physical therapy and other areas. These are some of the waveforms that have been used over the years when applying electromagnetic energy to either cell systems or animal systems or human beings. And most of you are familiar with the standard sine wave and maybe even the square wave, but you can see in the lower left-hand corner, that is a triangular wave, and to the right of that is a sawtooth wave. There are some applications, especially in orthopedics, where they use these kinds of waveforms to help heal non-healing fractures and in some other areas of orthopedics. And this work has been done by some very good people who have then patented this information and turned that into application devices for treatment of human beings. So what are the effects of non-ionizing electromagnetic fields? What is it about them that interests us so that we may be able to apply them? Well, the standard mechanism of action, if you apply them with enough power, is that you increase the temperature of what you are treating. And that is a clear mechanism that can be measured. It can be understood. And electromagnetic heating is fairly standard. And also in the treatment of malignancy, we have used hyperthermia induced by electromagnetic fields as a secondary kind of therapy for malignancy. This was applied both locally and systemically. But now more locally, the therapy that was applied systemically to induce total body hyperthermia proved to be somewhat toxic. Some of you may know that the original concept of using hyperthermia or high temperature for the treatment of malignancy dates back to the early 1900s, when Dr. Coley recognized that patients who had infections and developed very high temperatures actually showed regression of malignancies that they had at the same time. He then developed a cocktail, if you will, called Coley's toxin, which he would apply to people to induce high temperatures and try to induce regression of malignancies. On the non-thermal side, we're a little less clear about this, and this is part of the debate about what actually happens when you apply electromagnetic fields to systems. Here are some of the theories, as you can see, as to why these work or what the mechanism of action is. Manipulation of calcium channels, manipulation of the immune system, changes in cell membrane and cell protein pathways, and also signal transduction pathways. And also there has been work on effects on iron and iron metabolism. So EMF, or electromagnetic field induced hyperthermia, is generally either capacitive, inductive, or some other antenna that directs the electromagnetic fields toward the area that you want to raise a temperature in. In general, capacitive means that you are close or touching the area that you're interested in. The inductive type usually does not require actual contact. And the antenna, as you can imagine, you point the beam at the area that you're interested in designating as the hyperthermic space. So using radio frequency electromagnetic fields, you can actually heat tumors as part of a standard form of therapy. Now, this CT scan shows in the upper left-hand box, you see a kidney with a tumor. The tumor is growing downward out of the kidney, and it's a smaller peripheral tumor in that kidney, and therefore it is a tumor which can be treated using radiofrequency ablation or localized radiofrequency heating. This is done in place of surgery. And so, as you can imagine, even with laparoscopic surgery, there's still a much more rapid recovery from this therapy, and it can be done multiple times as opposed to surgery where people have to be prepared a little bit differently. Here we see in the upper right hand, we see the application of the catheters toward the area of the tumor. And then in the lower boxes, we see that there is, within a few days, there's already regression of that tumor. Now, the same thing is true for hepatic tumors. And here you see using radiofrequency ablation and applying the antenna-based introduced into the tumor, you can induce a hyperthermic space. And to doing that, you hope that there is enough vascular tissue in there to also carry the temperature so that you get complete regression of these tumors by being sure that you have completely occupied the space with the appropriate catheter, and that the hyperthermic temperature extends throughout the whole tumor. Now, these also need to be smaller in size. Generally, they're more peripheral. You can probably go a little bit deeper, but don't forget that a liver is considerably larger than a kidney, so you have to be very cautious, and it takes a little bit more time and effort by the people who are doing this kind of work to be absolutely sure that the tumor is in the right place, the right size, so that radiofrequency ablation can, in fact, completely ablate this hepatic tumor. Now, the more peripheral tumors generally carry a lower vascular risk. And those of you who deal with malignancy in the liver know that because of the vascularity of the liver, sometimes even doing percutaneous biopsies of the liver can result in some excess bleeding because of the vascularity. So that must be taken into account. And of course, if you can reduce the surgical intervention and you reduce the risks that accompany surgery, then that certainly is a big help. Okay, now bone metastases, I deal a lot with this with patients with metastatic malignancy, often goes to bone, and here we see a scan that shows a malignant growth on the right-hand side of this vertebral body. It has grown through the vertebral body and is causing displacement, and it's also makes it somewhat irregular and not as strong as it usually would be. And so ordinarily we would say that this patient should have ionizing radiation therapy to treat this, but with these smaller, more confined lesions, you can use localized therapy with radiofrequency ablation of the bone metastases. And this does a couple of things. The first, of course, is that it controls pain. And that's usually the reason why you are using electromagnetic fields to do this. And also you want to try and stabilize the bone. One of the terrible complications of metastatic disease to bone is that if a vertebral body is destabilized, you could have collapse of the spinal cord with paralysis. And so you want to treat these early if you can to allow some bone regrowth, stabilization, and then you can proceed with other kinds of therapy. Now, if you can avoid ionizing radiation, that does a couple of things. The first one is, of course, it does not subject the patient to ionizing radiation, which is clearly more toxic in general than the non-ionizing forms. You also may be able to prevent surgery, and often these patients require a surgical intervention to stabilize the bone prior to doing any other kind of surgery. If you do the non-ionizing RF ablation therapy, you may be able to avoid the surgical procedure. Now, moving on to other kinds of uses of electromagnetic fields, we come to electroporation. Now, electroporation is basically exactly what it sounds like, which is that you apply catheters to tissue or cells, and then very, very high voltage, thousands of volts, and it requires that high voltage to create pores, openings in the cell membrane. Now, these pores can be either reversible or irreversible, and certainly if you are using this kind of technique because you want to introduce something into the cell, then you want to be sure that you're using a technique that allows reversibility of the pores. If you introduce something in there, such as a gene or a transfection or something along those lines, you want to be sure that that gene introduced into the cell stays in the cell. Well, the same is true for chemotherapy, and we have seen a number of groups around the world that are using electrochemotherapy, and here electromagnetic fields and high voltages are used to open pores in cancer cells. Then the chemotherapy that is placed in the tissue in the area is taken up by those malignant cells, and then with turning the electromagnetic fields or electric power off, you then allow the pores to close, and you have a higher concentration of chemotherapy inside the cell than you normally would be able to get if you simply bathed that cell in chemotherapy. And so using that, there have been a number of papers published that suggest that this, in fact, is a useful treatment. Now, part of the problem with this treatment is that it really focuses more on localized malignancy than it does on systemic malignancy. As you can imagine, you would not generally be able to give someone a total body dose of thousands of volts of electricity to open up multiple pores. So this currently is aimed more at recurrent localized malignancies, but it has shown considerable success. Then there are nanoparticles, and nanoparticles are sort of a newer way to introduce pharmaceuticals into tissue, in particular, from my point of view, certainly malignant cells. Now here, as opposed to other kinds of therapies, what you're doing is you are taking particles, making them responsive to magnetic fields, and then placing magnetic fields over the area of the tissue that you are interested in concentrating those nanoparticles in. And then that allows the concentration to be high enough so that the malignant cells will uptake that chemotherapy and therefore increase the amount of therapy inside the cell and make it more effective. Again, this is aimed more for, as you can imagine, a more localized malignancy, but it has wide application because you can do this multiple times. If you operate on a patient, or if you use standard ionizing radiation on a patient, it's likely that you will not be able to give a lot more ionizing radiation to that space. However, as you can imagine, the magnetic fields, which are a lot more benign than that, you can apply these nanoparticles and the magnetic field many times in hopes of getting a good response. So then we have some pulsed electromagnetic fields, and this study was done to show that you can use pulsated electromagnetic fields, and you can allow chemotherapy to change how these cells multiply and survive, and also whether or not pulsed electromagnetic fields as a solo therapy can help to treat malignancy. Again, we are looking a little bit more at localized as opposed to systemic therapy. However, the point of a lot of this therapy is that it can be used multiple times with a low chance of risk and a high chance of benefit. On the right-hand side, you see an actual time diagram of what the pulse of magnetic field looks like, and those times are in milliseconds. So you can see that these are extremely rapid pulses that are used to treat these malignancies. So that brings us to static magnetic fields and anti-neoplastic chemotherapy. I often use ANC, or anti-neoplastic chemotherapy, when I am speaking to patients or to other physicians or medical students or residents, because I want to emphasize that the term chemotherapy in medicine really applies to just about anything you take, whether it's digitalis or penicillin or anything else. And so I like to use the term anti-neoplastic to be sure that people understand what the chemotherapy is. Now, we have traditionally used the term chemotherapy to indicate that we are giving someone a treatment for cancer. It's become part of the standard jargon, but I do like to distinguish that. So these are some representative papers that have come out since about the year 2000. The first one on the left is Gray's work, where they showed an enhancement of chemotherapy using static, electric, or magnetic fields. And these are some of the papers that helped us to determine how we were going to do our research. That came out in about the year 2000. And then the other work, which is Tofani and Luo and Gelrich, all also used the same kinds of ideas where you try to enhance the action of anti-neoplastic chemotherapy on malignant cells by manipulating those cells or manipulating the chemotherapy by using electric fields or magnetic fields. For the most part, these were 0 hertz fields. So they were not what we call time varying, so they did not have a cyclic pattern like you saw one of the earlier slides where I showed the sine wave and the square wave and so on and so forth. So these papers did help to lay a foundation. Then these two papers, the one on the left is one of the papers that we've published, and we were I believe, one of the first groups to consider applying a static magnetic field to a patient who was actually receiving anti-neoplastic chemotherapy for malignant disease. We considered it a phase 1 trial because it had not been done previously, and so we wanted to be sure that by applying these static magnetic fields, we did not induce more side effect or a worse side effect profile than the patient would ordinarily experience by receiving chemotherapy alone. On the right, the paper, and our paper, was published in 2003. On the right is a paper published by Ronchetto from Italy, and that was published in 2004. Now, the difference between their paper and ours was they used only static magnetic fields, whereas we used the combination of static magnetic fields and anti-neoplastic chemotherapy. However, both papers point to the fact that static magnetic fields or 0 hertz non-time varying magnetic fields could in fact be applied safely to humans for the treatment of malignancy. Now, when you apply a permanent magnet to someone, there are pros and cons to why you do it. And these are some of the pros that we felt were important to design the research and, of course, to tell the patients why we were doing this. So you can measure the field that comes from a magnet. You don't require a power source, and so that makes it easily placeable and easily movable. And you could use more than one if you wish. Also, magnets don't cost much, and they're reliable and safe. Basically, they produce the same amount of magnetic field all the time, and they're really fairly safe, as you know. Also, we realized that if something like this was functional, it could be done outside of a medical facility, meaning that people or patients might be able to apply a magnetic field after chemotherapy had been administered in our clinic, and they could apply a magnetic field not only in the clinic during the infusion of the chemotherapy, but they could also continue the application of the magnetic field after they left. We also know that magnetic fields can penetrate many materials. For example, someone who's wearing a cast for something, a fracture, a pathologic fracture or something of that nature, the magnetic field would probably penetrate. Also, you don't have to touch the skin with the magnet and the magnetic field. And also, something that may not be quite so obvious right away is that you specify which pole, the north or the south pole, that the magnet is pointing at the patient at the time that it's applied. Now, some of the things that are against it are that you really can't change the field strength of the magnet. What you see is what you get. What you measure is the way it is. They're generally less powerful overall than if you were to apply a magnet that was attached to a power source and whose strength could be varied. Also, the field is non-time varying at 0 hertz, and that may have an effect and may mean something in later studies. Also, if the magnet is in place, if there's movement during the application of the magnet, that could affect the efficacy. We tried to eliminate that by being sure that we had tattoo marks, just like they use with ionizing radiation, so that the magnet could be placed on our patients in exactly the same position every time. Also, you can only use the one strength and one polar direction at a time, whereas time varying fields obviously change from positive to negative over time. Also, the depth of the penetration. It's generally unique. You can't vary that. You certainly can't push the magnet closer or further into the body or anything like that. So that is a problem. And finally, as we alluded to earlier, we really don't know why or how non-time varying or 0 hertz static magnetic fields work, but certainly there's enough information in the literature for us to say that it's a good reason to study it further. So static magnetic fields and anti-neoplastic chemotherapy, we felt that maybe the local therapy would affect systemic response. In other words, if we placed a permanent magnet over the patient's liver and we knew the magnetic field and we knew that chemotherapy was passing through the liver, it was possible that the magnetic field or other issues could be changing the way the chemotherapy was processed by the liver or other possible theoretical avenues. So what we did was we placed the magnet about 15 minutes prior to the infusion of chemotherapy, during the infusion, and for about 30 minutes following the infusion. And the patient was marked to ensure the location of the magnet. And we also asked them to move absolutely minimally during the time period that the magnet was in place. Of course, as we also made routine and constant background field checks, and we also were careful to note what kinds of magnetic or electric or electromagnetic fields might be coming from the equipment that we were using in the clinic to infuse the chemotherapy. So on the right, you see a magnet. It's a little bit magnified for the size, but it was placed generally over the right hepatic lobe of the liver. We marked where it was. We put the angle so that we would maximize the amount of the magnet that was actually over the liver at any one time. And we did that by doing careful physical assessments of the patient. So we were able to outline the liver by physical examination and then place the magnet over the liver. So since this was a phase 1 study, we were very interested in whether or not there was excess toxicity. And that really is what a phase 1 study is supposed to do. It's supposed to tell you whether or not the treatment that you've embarked upon is either so toxic that it can't go any further or has minimal toxicity and can proceed. And the result of our study did show that when compared to matched controls, the patients who had the magnet placed showed no enhancement of hematologic toxicity. What that means is that white counts were not lower, platelet counts were not lower, more severe anemias were not induced, and hepatic toxicity was not enhanced either. So in spite of the fact that the magnet was over the liver, we did not see an increase or a worsening of hepatic toxicity over what we would expect from just the chemotherapy alone. We also noted that other kinds of systemic toxicities were not enhanced. For example, patients did not develop a rash more often if they had the magnet in place. Kidney function generally remained okay, was not worse with the magnet group. So we concluded that certainly using the configuration that we designed, you could apply a static magnetic field to a patient who is receiving anti-neoplastic chemotherapy, and that it was safe for further human investigation. Now, we've taken this data a little further. We have not written it up and published it yet, but we've been looking not only at long-term effects, because the phase 1 study was more short-term effect, but we were looking more at long-term effects of the magnetic field. And because we have age-matched controls, whether or not there was even a suggestion that possibly those patients who had the magnet in place had a better outcome than patients who did not. We do not know that yet, but we are studying that. That also led us to begin design on newer studies using similar magnet and chemotherapy designs, and those are in the works. So the future directions are to continue to study to determine efficacy, and that's currently part of what we're doing. Does the combination of a static magnetic field and anti-neoplastic improve the outcome when you're treating a patient with malignancy? We're going to continue to use the permanent magnets because of low cost, easy application, low risk of toxicity. And we also note that the studies that we did used mainly standard anti-neoplastic chemotherapies. As many of you know, there's been an explosion of other kinds of anti-cancer therapies now with biologicals, immunologicals, tyrosine kinase inhibitors, immune checkpoint inhibitors, a whole vast array of new kinds of anti-neoplastic pharmaceuticals that we would very much like to use in some studies. Now, patients who are unable to tolerate or want anti-neoplastic chemotherapy may also be patients who would be candidates for just electromagnetic field or static magnetic field. As we saw earlier, there was a paper published which used just static magnetic field as a therapy. And so as a solo agent or possibly even as an adjuvant to ionizing radiation therapy, static magnetic fields, use of magnets may in fact be a viable option for other kinds of treatment future directions. And so that will end the talk on using electromagnetic fields in cancer therapy.